from Maimar Talegaon.
C from Grand Government Medical College, Mumbai.
In particular, I want representing all of those who are listening to this lecture or slide seminar, and they will answer the questions, and probably you will get a feel of what the problems on Telegram. Now, most of you have had lectures on bones, and some of them were very good, particularly the ones that was done by Dr. Vikram Deshpande from from the Mass General Hospital, and you had somebody who was excellent, who was a clinician, who also told you how to look at radiology. And I think all of you know that you should not be reporting on anything or even trying to evaluate slides, gross appearances of bone lesions without having access to the radiology. And today, imaging is more than just a plain X-ray. It is CT scans as well as MR. So let us see how we approach these tumors.
Sorry to interrupt, ma'am. Your video is off, ma'am.
My video is off. Oh, I'm so sorry. 1 minute. Let me see if I can. I should get it on, right? Second. Let me get this off and then I'll switch my video on. Let me stop sharing for a minute, okay?
Yes, ma'am.
All right. Now can you see me?
Yes.
Now I'll share my screen. It's just. Okay. Thank you for. Yes. Now you can see me and you can see my screen, right?
Yes, ma'am.
Yeah. All right. Good. So now let's get to the first case, and let's see now who would like to take the first case. Anybody can volunteer, but many people don't volunteer. So let me ask Mansi. Mansi, you're there? Okay. Come on, Mansi. Start.
This is a case of 59-year male and open biopsy of lytic lesion in the distal end of right ulna is given to us.
Very good. So you saw. I think I also shared the radiographs.
Yes, ma'am. On the radiology.
1 minute, Mansi. What's on the left-hand side and what's on the right-hand side of the screen?
On the left-hand side is the X-ray, and on the right-hand side there is a CT scan.
There's a CT scan. Why do you say that's a CT scan, Mansi?
And the appearance of the lesion.
Appearance of the lesion tells you what is a CT scan. What? Mansi, why do you say that is a CT scan?
Ma'am, the appearance of the soft tissue and the
appearance of the soft tissue. All right. Mansi thinks it's a CT scan, and on the left-hand side, you think that this is a plain X-ray, right? Yes.
Yes, ma'am.
All right. Now let me ask some of the others. Monica, do you agree with Mansi?
Yes, ma'am.
What do you agree with? Do you agree with both her statements that on the left-hand side there is a plain X-ray and on the right-hand side is the CT scan, right?
Yes, ma'am.
All right. Monica thinks it's that. Let's ask Sarangi. Sarangi?
Yes, ma'am. On the right-hand side, it is the CT scan, and the left-hand side, it is X-ray.
It's an X-ray. Prayas?
Yes, ma'am.
You also agree. Very good. Ritu isn't there. Hema?
Yes, ma'am.
You agree. My God, you're all yes men and women. Zara?
Yes, ma'am.
Yes, ma'am. Do you see some words that are written on apart from right, left, which is there on the right-hand side? Yes?
Yes, ma'am.
Left-hand side. Do you see some words written on the right-hand side?
Yes, ma'am.
What are the words, Manasi?
Spin and tilt.
Tilt. So what is spin and tilt? What is spin and what is tilt? When do you see these? Mansi, have you ever looked at a CT scan? Have you, you must, when you're doing pathology, you know that we say that we should be clinicians first. And all clinicians look at CTs, do they not? Yes, Mansi?
Yes, ma'am.
Oh, very good. Mansi, have you, in which, I've forgotten now and you have to forgive me, but are you a second-year student or a third-year student or what?
Second year.
Student. So by which time you have done some histopathology, right? Yes or no?
Yes, ma'am.
Okay, how much histopathology have you done, Mansi?
4 months, ma'am.
4 months of histopathology. All right. Then let me ask Zara. Zara,
yes,
have you seen a CT scan ever?
Yes, ma'am.
You have? All right. So have you ever seen these two words on a CT scan? Spin and tilt?
I guess they're on the MRI.
Have you?
No, ma'am.
No, because you never paid attention, right, to what you see there. You just, in fact, I don't think that anybody even really is worried about reading either a plain image or looking at what is said on a CT scan, etc. Do you know that there are such things as Hounsfield's units on a CT scan?
Yes, ma'am.
Yeah, so what do they stand for, Zara? Anybody will be able to tell us? But let me tell you that this is not a CT scan. Spin and tilt is something that is used in MRs. Okay, I get your problem that sometimes it's not easy to tell what is a CT scan and what is an MR. Okay, but here you see that there is a spin and there is a tilt. Okay, which means it is in MR. It is about the spin of the nuclei that is being calculated by the magnet. Okay, the magnet is rotating and you get the spin of the nuclei which produces these images. So no, it is not a CT. All right, this thing is actually an MR. Okay, anybody in the chat box had answered the question? Loma or Vatsala?
Yes, ma'am. One has mentioned both cortex is white, so CT, and another person has mentioned MRI, and one of them has written there CT.
Some has written CT. All right. You know that the cortex can be white or black depending on whether it is T1 or T2, no? So that's always an issue when you come to MR. Okay, that's neither here nor there. Now we are not trying to read an MR or a CT, whatever the case may be. But can you tell me something, Mansi, about what you're seeing on the left-hand side? Because all of us are very happy to look at plain X-rays. Yes. Come on, Mansi, can you read that plain X-ray?
On the left-hand side, the X-ray shows a lytic lesion over the lower end, over the distal end of ulna, which is eccentrically placed, and similar lesion is noted on the metacarpal also.
is seen in the metacarpal. Yeah, okay, very good. And how would you describe that lesion?
It is a lytic lesion with regular borders.
Irregular borders. All right. So
It is
now
not a
let us say, what is it that you should know about an X-ray? Because we do it once here, and you'll be able to. I think most people should be able to do it in all of the cases. We have 4 cases to look at. Okay, so come on. What do you have to say about reading an X-ray? And this was done beautifully in more than one of the previous lectures. Mansi, what should we notice about any bone X-ray?
The laterality first, and then the view, whether it is AP, then the location of the lesion, whether or not all the bones are in anatomical position, then the location of the lesion, then the nature of the lesion, whether it is epiphyseal,
Mansi,
metaphyseal.
what do you need to say about location? Location means what?
Ma'am, epiphyseal.
Which bone or what?
Ma'am, ulna. This lesion is located on the ulna, on the epiphyseal and metaphyseal region of the ulna.
Epiphyseal and metaphyseal lesion of the ulna. All right. Very good. So you said that this is at the end of the long bone, right?
Yes, ma'am.
Yeah, of this ulna. Then
it has a scalloped.
very good. The bone has been scalloped. You can see that it is very nicely scalloped, because you can see that this thing has scalloped the bone. Now the meaning of the word scallop is what, Mansi?
It's like taken a scoop out of it.
Very good. Excellent. It has taken a scoop out of it. Yeah. All right. What do you want to say about the other lesion that you've seen over there?
Ma'am, it is also kind of, but ma'am, that is also a lytic lesion, but it does not show peculiar scalloping of the.
All right. So what does it show you?
Multifocal.
It's a lytic lesion which seems to. It's very moth-eaten. Don't you see that? It has not got a very good zone of transition. Here, yes, it's a scallop, which is a very clean zone of transition between the lesion and the bone. But what else do you see, particularly in this ulnar lesion?
Area of calcification.
Areas of calcification. Okay. What you see when we look at the bone? Yes, we see whether it's at which part of the bone it is. Whether it is, if it's a long bone, is it at one end or the other of the long bone? Whether it is epiphyseal, whether it is metaphyseal. We also need to know beforehand when we look at it whether this is a mature skeleton or not a mature skeleton, right? So is this a mature skeleton, Mansi?
Yes, ma'am.
How do you know it's a mature skeleton?
And the fusion of the plate.
Fusion of what?
Growth plate.
The growth plate. What is that growth plate called, Mansi?
At the junction of epiphysis and the metaphysis of the bone.
Yes. So what is that growth plate that we talk about? It's the epiphyseal cartilage, right? Right. Now, Mansi, how do you know that this is a mature skeleton? This thing has eaten away the whatever is seen over here. So can you show it to me on the other side? You asked for annotation, and I
yes,
can yeah. Okay, you got your pen?
Yes, ma'am.
Very good. Now show me where this fused growth plate is on the other side. What are the bones that you can see on the left?
Here, is it visible?
Yes, I can see what you have drawn. I think it's a vermilion mark. Yes. So what do you see there? What is that line?
That is the line of fusion, ma'am.
It's the line of fusion. So what was it before?
It was the cartilage.
It was cartilage. So how would it have looked like if it was not fused? Now you're seeing it as a white line, right, Mansi? Yes, you're seeing it as a white line. Here it is, that white
Yes,
neat line. Yeah, between your red vermilion and my red, you can see a white line. Everybody can see it. So if it had not been fused, what would that line have looked like?
Like a translucent.
Translucent. Translucent to what, Mansi?
Black. More.
It would have looked black. It would have looked black. Why? Because
no mineralization.
No mineralization. No, that's because it was cartilage, and cartilage allows X-rays to pass through it. No, without any problem at all. How do we know that? Can you tell me how we can know that in the rest of this X-ray? Can you see cartilage in any part of the rest of this X-ray image, whether it's on the left side or the right side? Is there cartilage anywhere that you can see, Mansi? Is there any cartilage that you can see? All right, while Mansi is looking, let me ask Hema. Hema, can you see cartilage?
No, ma'am, I don't see any cartilage, ma'am.
You cannot see any cartilage. Okay. Monica, can you see cartilage anywhere in this whole image? From here to there, anywhere. Can you see it?
PC form.
Monica, you can see?
PC form would not have matured.
PC form is a bone, right? All right, Sarangi.
Ma'am, between the tarsal bones.
Between the tarsal bones. All right. Are there good joints between all of these bones? Where would you expect to find cartilage? See, Manasi, when a question like this is asked, you're looking carefully at the image. But what your mind should have been asking is, where would I find, if I had to look at cartilage, where would I want to look? So now, Manasi, that I've given you a hint, where would you want to look for cartilage? Where, Manasi? Anybody? Where would you want to
Joint space.
the joints. Now you see this, both these hands. Do you know how many joints there are in our hands? Now we've got the wrist joints, we've got the metatarsal phalangeal joints, we have all of the joints of the phalanges. Yes, and there are joints, yes, between the tarsal bones, yeah, which don't move. Okay, we can't move our tarsal bone joints. We can only move the wrist. We can move these. So you should be able to see cartilage here. So can you see the cartilage, Mansi? And the answer is yes, there is cartilage there, because there is a black line at each joint. Okay, so you didn't have to look very hard, Mansi. What I'm trying to tell you is that when a question is directed to you, to all of any student or anybody, all right, the first question you have to stop and think, your mind has to stop and think, is where am I likely to find whatever it is that I am looking for? Okay, even if you've lost your keys, all right, where is it likely that I will find my keys? Yes or no? Where were my keys yesterday? Where did I put my keys when I left home this morning? So your mind has to ask that question. And the question is, I am likely to find cartilage where there are joints. And look at the number of joints. And at each of these, it looks as if the bones are separate from one another. Yes or no?
Yes, ma'am.
And what is separating the bones are the joints. And every bone will have a cap of cartilage at the ends where the joints are. Have you all understood that?
Yes.
Zara and
Yes, ma'am.
Prayas and all those who were not asked the questions. Okay, so that's where the cartilage is, and Mansi was absolutely right that this has fused on the left-hand side. This is a mature skeleton because you can see that the radial epiphysis, the lower end of the radius, has an epiphysis, and it is no longer black; it is white. So it means that this has got ossified, and that's the reason that this is a mature skeleton, because the epiphyseal plate is no longer there. And now you have, whether the epiphyseal plate is there or not there, you know that there is a line that divides the epiphysis, which is distal from that line, from the metaphysis, which is proximal to that line, and then you have the metaphysis is just a vague kind of zone. And once you come where the cortex is thick, you start the diaphysis. It's a kind of a very no man's land between the metaphysis and the diaphysis, but there is a clear line between the epiphysis and the metaphysis. Okay, has everybody got that? Okay, very good. Now, Mansi, you were describing this lesion in the bone, right? Now, you told me it was scalloped. So now, can you tell me what this scalloping is due to? Because you see that there is a fairly well circumscribed lesion, which is not in the bone. Is it in the bone, Mansi?
Arises from the cartilage.
It's not arising from the cartilage. It is actually in
Cartilage
soft tissue, and the soft tissue has eroded or it has scalloped the bone. And when you look at the other lesion, there it is a little difficult to say whether the lesion has arisen in the bone or it's in the soft tissue. But as far as this ulna is concerned, there is no doubt that there is a large soft tissue extension, and it may actually be a soft tissue lesion that is scalloping or eroding the bone. So that's what we know when we look at this. Now we also know that there are two lesions in this bone, in this near the wrist. Okay, one is in the metacarpal, the other one is in the. So what does two lesions tell you? When you see two lesions, what should you be thinking about, Mansi?
And the lesion is multifocal.
Yes, thank you. That's what we said. There are multiple lesions. Okay, so what does it mean? You know, Oshan and Rajendran and a few other people, please don't put your cursor anywhere near that little squiggle because I'm getting lots of requests for annotation. Yeah. What does it mean when you have more than one lesion in bone? Anybody else besides Mansi? Come on, Monica, what does it mean? What are the possible reasons why you have more than one lesion in bone?
Ma'am, hyperparathyroidism.
Hyperparathyroidism. All right, very good.
Enchondroma.
Enchondromas. Okay.
Ma'am, fibrous dysplasias.
Fibrous dysplasias. Okay.
Ma'am, myeloma.
Myeloma. Very good.
Vascular tumors.
Vascular tumors. Do you think when somebody says that you've got multiple lesions in bone, what's the first thing that comes to your head? It's metastasis, right? So yeah, myeloma, metastases are the things that in which multiple bones are involved. Okay. Then of course comes what kind of lesion is this in the bone? All right. Is it punched out? Is it destructive? All right. Or as in this case, these multiple lesions are surrounding or very close to the wrist, so that the bones are not one on the left, one on the right, somewhere they're all around the wrist. So you get one near the ulna. And if you look at the other side, when you see this other image, you see that one of the, it's not just the metacarpal that is also gone, but the tarsal bones are also affected by this, by whatever this process is. So this is a process that seems to have affected many of these bones that are around the wrist. Okay, so that's, and also this is not sharp. There is a circumscription to the soft tissue part of this lesion, but all of the others, they're not very sharp. Okay, so it's a very irregular lytic process that is going on in the bones around the wrist on the right side, mainly on the around the ulna and the metatarsals. That's it happens to be the fifth metatarsal because you've got the thumb towards the middle of this image. All right, very good. So now, Mansi, come on.
This is a low power of the H&E slide given. It shows a fragmented biopsy with areas of this one cartilaginous areas are there. Then a few myxoid areas are present. There are hemorrhagic areas. So and it is a hypocellular lesion.
It's a hypocellular lesion. Very good. Okay. Are you seeing myxoid areas and hemorrhagic areas, Mansi?
Towards the right
Yes,
side.
I can see that. Do you think that this is hemorrhage? Hemorrhagic areas? You know what is the meaning of hemorrhagic areas? When you say that something is a hemorrhagic lesion, what does that mean, Mansi?
Not the lesion per se, but the area over there. I was saying about. Ma'am, just the area over there. I was saying
about. They could do a biopsy without some blood being shed. Yeah, is it possible?
No.
Huh? Can you make an omelette without breaking eggs? No. Right. So there will be some. So you know this is a way, Mansi, of getting away from describing what you should be describing. Okay. You said there are some myxoid areas. Now, Mansi, you want to show me this myxoid area?
Ma'am, request for annotation. Ma'am, I'm asking for annotation, but there's some issue with this.
See, wait a second. There must be some technical issue.
Connection issue, I think, madams. Madam must be rejoining.
Uma,
Yes, ma'am.
can you hear me?
Yes, ma'am.
All right, what happened? We lost our connection or something?
Yes, yes, ma'am.
All right, it's okay. Chalo. So now, Mansi, you are going to tell me, ask for annotation and show me where are these mixoid areas.
This is the cartilage where I put a C, and
In a little bit is
these-
cartilage. There is a little bit of cartilage elsewhere. Now, will you show me where is your? That's mixoid. That's cartilage, right? Why is it mixoid? Huh? There is no mixoid over here, Mansi. So we are seeing cartilage and something else. So what is that something else, Mansi? What are we seeing?
this looks like a sclerosed.
It looks sclerosed to you. Mansi, before we start interpreting something as being sclerosis, we have to describe it. So will you describe what you're seeing? Please describe what you're seeing.
Ma'am, this is a
You were right when you said that you did not see cells. It is extremely
Hypocellular.
hypocellular, almost acellular. So what-
acellular areas.
Acellular areas.
And
What you see is just
nodule-
one big acellular
Fragment.
piece of tissue. You're saying acellular material, but please describe that acellular material, Mansi.
Which is homogeneous eosinophilic. At few places there
Homogeneous
is chondroid areas. Now
Chondro-
here, ma'am, it is nodular. Like
Okay, you're seeing nodules of what? Nodules of what?
matrix.
Each of these things, Mansi. Can you not describe this? Describe it. I'm not asking you to even make up your mind as to what it is. So you have a description, and that description then leads you to an interpretation. All right. This is true of whether you are talking about cells or you're talking about extracellular material. If you describe it, then you can interpret it. So, all right, Mansi is finding it difficult to do it. Come on, Zara, help Mansi out. What are you seeing?
Ma'am, there are acellular areas comprising of amorphous, pale eosinophilic material.
Fantastic. So what you're seeing is nodules and sheets. You saw that there. Here it is nodular. Here you have nodules. Yes, you can see that. And together they are confluent nodules of pale in
Eosinophilic.
pink. Yes, it's eosinophilic, but it's extremely pale eosinophilic. In some places, it's not even eosinophilic. It's like grayish. All right, material. Can you see
Yes, sir.
that it is grayish, pink eosinophilic material? Yes, that is extracellular and acellular. Now, Mansi, that is not difficult to wrap your head around. Zara has helped you to say what it is. What else do you see now? Come on, Mansi. Yes, that's not all you see because it's not all pink or gray that you are seeing over here. What else do you see? Have you disappeared, Mansi?
Ma'am, I'm here. I was just
Go there.
checking. There was some issue with the connection. Now it's okay.
All right. So what do you have? There's a lot of blue, right? So what is that blue? You can see blue here at the top left-hand corner. And you see blue that is around the...
Let's say islands of cartilage. This is the cartilage in this area. I think madam has some connection. Matrix.
Yeah, I think I'll check it, madam. What's the issue? Anita, can you hear us? I'll check. I think we all are aware of Dr. Anita Borges' connection is getting problem. So students just bear on. Hang around. I'll check it, Anita. I think she's working on it, so give me 2 minutes. Possibly Dr. Borges' connection has gone. Yeah. What's up? We are there and everybody else is there. Yeah. I'll just give 2 minutes.
It won't.
Yes, Anita, we can have you. We have you back.
I know that, but I think my geo connection is bad. Let me share again.
Okay.
I'm trying to do something. I'm trying to get another... All right. Come on, Mansi, you've seen something over here?
Cartilaginous or
Very good.
chondroid
There's
areas.
cartilage, and then there is this blue area around here, which let us see if we can see something at higher power. Okay.
And these are the areas of calcification.
Yes, very good. What else do you see now, Mansi?
And there is this nodule which is surrounded
Surrounded by?
by cells, and these are spindle cells. And this the nucleus along with osteoclastic giants.
Mansi, can you talk a little louder so that everybody can hear? Yes, there are osteoclastic giant cells, and you've got some...
Ma'am, this nodule is surrounded by spindle cells and along with molar cells and glass-like cells. And there is also calcification in one of... Yes, ma'am. Here it also shows calcification.
Okay. Can you say something about the calcification, Mansi?
Ma'am, it is a coarse kind of
Coarse kind of calcification. All right. What do you want to say about the calcification over here? Are you going to say that this is only coarse kind of calcification?
It has got a peculiar structure.
It has a structure. Okay. What is the structure, Mansi?
Ma'am, it is like star kind of a calcification,
It
star
is
shaped.
star-shaped calcification. Yes, Prayas, you wanted to say to ask something. What is it that you wanted to ask?
Ma'am, it's some floated and some crystals looking like needles.
This has a star shape. The calcification is not star-shaped, Mansi. Prayas is telling you something.
Huh.
That there is,
Crystals.
yes, there are, yeah, they look like crystals, right? So there is sort of needle-like crystals which have all come together to form a kind of star shape. Okay, so if you go back and you look at what you're seeing over here, look at this. You have got some cellular component that is surrounding these large areas of acellular material, which is, you know, there is a word for this. And that's why I want you, people to understand this word. It is used in some situations where you get this extracellular deposition, and that word is floccule. Do you know what is, have you ever used the word floccule, Mansi?
Okay.
No, floccule is a fluffy kind of loose deposit. Okay, so you can see that this is not tight. This is not like hyaluronized collagen, which is almost like a sheet that has got no folds in it. Yeah, here you can make out that there is a kind of a fluffy deposition. Let me get my pointer. All right, see the fluffiness of all of these areas. So it's fluffy. You know that it is not a thick sheet, because in between you have areas where there is no deposition of any kind. All right, and this word floccular is very, very evocative of some kinds of depositions in the extracellular material, and one of them, which you see much more commonly than what you're seeing here, is amyloid. So the amyloid is floccular depositions that you see. Now, once you know what floccules are, you know, like a cloud. Yes, you have floccules of clouds are also, when you get a sort of a thickish cloud, that is what is flocule. And if you think about it, that's what this really, brings to your mind. That is what is the meaning of the word evocative or evokes. And around this, just like around amyloid, you see that there is a cellular deposition. Okay, sorry, there are cells which are around it. And then you see something that looks like osteoclastic giant cells. And you also see other things which are not osteoclastic giant cells. What are they? They are foreign body giant cells. So this is evoking some kind of response. Yes, you look at this. See this at the bottom right-hand corner, you can see the foreign body giant cell reaction. And Mansi, if that is a foreign body giant cell, then what do you think all these other cellular areas are? What do you think they are? If you've got foreign body giant cells, and then you've got this grayish, pinkish material in which you've got these crystals, and you know that they are crystals now, the crystals have begun to show deposition of calcium, because this is dystrophic now, dystrophic calcification. So what do you think these other cells will be? Come on, Mansi, that's not difficult. What will those other cells be? Here you are. You're seeing them at high power. And you can see the foreign body giant cells. Yes, and you see these cells. So what cells do you think they are? Now, I hope you're describing them in your head. Huh? You're describing them in your head. Can you describe them loudly for all of us to hear? Prayas has again raised his hands, but let Mansi answer, then Prayas, you can. What?
Inflammatory epithelioid kind of cells. Some are
epithelioid-like cells, very good. But you said inflammatory epithelioid-like cells. So would you like to tell me what an epithelioid cell, which epithelioid cell you're thinking about? Huh? If these are epithelioid-like cells, and you are on the right track, Mansi, what epithelioid cell are you thinking about? Epithelioid comes after the word epithelioid. Huh? Epithelioid? No? All right. Before I ask, let me ask Monica, what epithelioid cell is Mansi thinking about?
These are histiocytic collection.
They are histiocytes. Is that what you wanted to say, Prayas? Prayas?
Yes, ma'am.
You raised your hand. So did you think that they were histiocytes? Or did you think something else, Prayas? What did you think? Come on, Prayas, you raised your hand. What do you want to say?
Mixed inflammatory cells. So
Mixed inflammatory cells. Prayas, I do not see mixed inflammatory cells. And you know, if there's one thing that irritates me, I'm sorry, I have a lot of patience, but it is mixed inflammatory cell that irritates me. Lymphoplasmacytoid cell is another thing that irritates me, because very often these words are used in a most, in a lazy kind of way. All right. There are no mixed inflammatory cells here. There are only histiocytes. And all you can see are these histiocytes. Yeah. And some of them, yes, have an epithelioid character. Okay. So I wouldn't, object to somebody calling this an epithelioid type of histiocyte. But you see that they're not forming small little granulomas like the usual epithelioid histiocytes do. What are they producing? Yeah, Mansi, would you like to say what this is all doing? And you've seen it before, although you say you've done only 4 years. 4 months in histopathology. Anybody has done more than 4 months in histopathology over here? Monica, how many did you do? 10 months. Now come on, Monica, tell me, when you see histiocytes like this and you see them arranged in this really typical kind of way, what would you say about this kind of reaction? Because it's a
This is a foreign body type of reaction.
Madam's connection, I think, lost. We need to wait. Huh?
Anita,
Madam's.
what happened, Roma? The connection got cut again?
Again, it's a connection issue, I think.
Yeah,
Madam's
that's
reason.
what I know, students. But she's there, I can see her.
Yes, madam is trying.
Yeah.
She'll rejoin again.
Yeah.
I understand, but my connection is very, very unstable. I think I'm back, hasn't it? know that, but it's you can't hear me. I can't hear you guys. It's a real. Can you now? Can you hear me now? Can you see me? Can you hear me? No.
Yes, ma'am.
No. Loma says she can hear, so I think I must be back. But I'm sorry that this is going on, and if it goes on more often, then we may have to do it another time. I don't know why this is behaving today this way. All right. Yeah, that's what I'm going to try and do. I've also got another dongle, so let me see. Okay. Yeah. Okay. I'll try. All right. All right then. Bye. Bye. Okay. Now you're back. Sure. So I think the word that you want, Monica, and all of you, is that this is a palisaded granuloma. No. See this. This is all. And do you know what a palisade is, Monica?
Yes, ma'am. It's kind of fencing around.
It's a fencing. Why is it called a palisade? What is this fencing? If you have to describe what fencing is, what is it?
Actually, there's a foreign body. And
No,
around
that's not what a palisade is, because there are many things that can form palisades. Yes, you said
Parallel, yes.
Mansi, very good. Yeah. So what is this? What is it?
Ma'am, these
There are
histiocytes
many
are
things parallel to one another, but all of them, they first of all, you can only get a palisade if you've got a cell that is long, elongated. All right. So you have got elongation. The second thing that is that the cells have to be parallel to one another. Yes, but they have to be perpendicular to the direction in which they are running. So this is the direction in which the palisade is running, and each of these cells, elongated cells, just look at them, are all parallel to each other but perpendicular to the direction in which they are running. Okay. So that is what is a palisade. Okay. Do you understand that now? So this is a palisaded granuloma, and no prayas, this does not have mixed inflammatory infiltrate. These are all histiocytes. So very good. Now what do you see here, Mansi?
woven bone.
Woven bone. Okay.
Central
Is
area.
that the main thing you see over here? You see
And
cartilage, right?
chondroid
So
matrix.
you see cartilage, and you see this is not woven bone. Okay, this is destroyed bone. You can see the lines that are concentric. So this is old host bone that has been destroyed.
Destroyed.
And, yeah, and that's what you saw in the X-ray. And you see these grayish, pinkish, floccular deposits. They are little soft. You know that soft is something that you feel. At the same time, when your eyes can also see a texture. Softness is a texture. So when you're holding you see a rock somewhere, you're not feeling the rock, but you know that is very hard. Okay. So similarly here, the texture is soft, and this is the word that you should all be able to use, and that is floccular. All right. So come on, Mansi, what is it that you have observed over here? We have seen.
There are nodules of floccular deposits which are surrounded by granulomatous reaction,
cells.
which is histiocytic, as well as foreign body giant cells are also present. So that is a palisaded granuloma pattern. And there are areas of needle-shaped crystals which are within the calcification area.
Yes, and the deposits have almost invaded, so to speak, destroyed cartilage and some remnants of bone, which are seen in this biopsy material. Okay, so now come on, Mansi. If we had to make an analysis of this, this is how we make an analysis. Okay, we start by asking ourselves, is this congenital or acquired? So what do you think, Mansi?
Acquired.
It is acquired. Very good. Is it physiological or pathological?
Pathological.
Okay, can you acquire a physiological condition, Mansi? Is it possible to acquire a physiological condition? Yes or no? Yes, then can you give me an example?
Some enzyme defects.
Sorry?
Enzyme defects.
Enzyme defects are physiological, which you acquire? Huh? Mansi, we're talking about histopathology over here. If you have dysfunctional uterine bleeding, is that physiological or pathological? Or if you have an ectopic pregnancy, or you have, so that's physiological, right? So pregnancy-associated conditions, etc., can be very physiological. All right, so is this physiological or pathological?
Pathological.
Pathological. All right, good. So now is it non-neoplastic, neoplastic or non-neoplastic?
Neoplastic.
Non-neoplastic. And if it is non-neoplastic, which of these non-neoplastic conditions is this? And I've just listed out what is in the general pathology chapters of any of your textbooks that you read. Starts with cell injury, cell death, adaptations, right? So now come on. Yes, Mansi, which is it? There you've got 1, 2, 3, 4, 5, 6, 7. That's all the choices. So which is it, Mansi?
Metabolic.
Who said metabolic? Who said metabolic? Mansi, you said metabolic or somebody else said metabolic? Whoever said metabolic is absolutely right. It is a metabolic disease. So which metabolic disease is this, Mansi?
Gout.
Gout. You don't know that it is gout. You have to prove that it is gout, okay? It is a crystalline arthropathy, and gout is one of the most common variants of a crystalline arthropathy, okay? So what are these crystalline arthropathies? They constitute a spectrum of inflammatory arthritis induced by a cellular reaction to crystal deposition in and around joints. So that was very, very important to know that this thing, even on radiology, was not just anywhere. It occurs in and around joints, okay? They can be primary or they can be secondary to an underlying metabolic or endocrine disorder. And I think there is too little time for me to talk about crystalline arthropathy, but please go and read about all the different kinds of crystalline diseases that deposit around joints. And this kind of crystalline arthropathy, that's gout, is usually non-birefringent. So you can't see it if you lower the condenser of your microscope, you will not see it shining, okay? There are lots of crystals that will shine if you lower your condenser and you cut the amount of light, but this does not shine, okay? So it is non-birefringent. Multiple diseases may coexist in the same joint of the same individual, so all of it need not be gout. And imaging has a crucial role. And this one of the roles you actually saw. You saw that all of this, there were deposits outside the joint that seemed to erode both the joint and the bone. Right? But there is something. These are just the common crystals, and this is how it looks like in urine. These needle-like crystals you are able to see like this, and you see how beautifully that it has the shape has been outlined by these by the calcification. All right, the next most common is calcium pyrophosphate, dihydrate, which is known as CPPD, and you have the basic calcium phosphate and calcium hydroxyapatite, which can also cause a crystalline deposition, and sometimes you get cholesterol and other things around joints. All right, and you know that you can also get crystals of which charcoal-laden crystals when you get a lot of eosinophils within any lesion. Okay, now I just want to tell you that here you have the same individual. These are the feet, and you know that gouty tophi are very common near the big toe. Yes, you can see the gouty tophus over here on both sides of the big toe. You can see it here on the right hand side. The left hand side seems to be more or less okay. And this is what I mean by imaging. Okay, it just looks beautiful and very colorful. Sometimes the patient gets pain. The patient has got swollen joints, or very sometimes minimally swollen joints, and your uric acid, when you estimate it in the serum, is not high. And this is a very useful way of being able to show these gouty crystals. The green, you can, they made it green here, but it could be any color. You just have to, this dual energy CT will show you the green deposits, as in this case, of gout. Now I want to show you this X-ray. All right, this is the right knee, and you can't make out any gouty deposits over here. But when you do the dual energy CT, see, it picks up even very small amounts of the gouty crystals, and that means monosodium urate. This is really a very useful way of imaging if you are in doubt as to whether the patient actually has or does not have gout. All right, so the answer to this question, this particular case, was that this is crystalline arthropathy. The most common one that you see is gout. Okay, good. Now who wants to take the next one? Oh, anyway, before we go to the next one, here is another case. You see this big, huge mass, destruction of multiple bones near the shoulders. So it's the clavicle and the lateral end of the clavicle, and you have the scapula has been completely destroyed, and there is a huge mass over here in the soft tissues. Okay, so what people would wonder whether this is a soft tissue tumor that is destroying bones, but in the end, it didn't turn out to be a soft tissue tumor that is destroying bone. This is what it is. So now, who's going to tell me what it is? Prayas? Prayas, do you know what this is? Is Prayas there or he's left?
Yes, ma'am.
You're there. So what are you seeing over here, Prayas? Can you describe it? And there must be people in the chat box who are writing over there. But if Prayas can't answer, then Zara, you'd like to take a try and say what this is?
Histoplasmosis.
It is what, sorry? Prayas, what did you say?
Is it, ma'am, histoplasmosis?
Histoplasmosis. Prayas, you're not describing this. You're just trying to match pictures in your head. Would you like to describe it, Prayas? Loudly? Huh? What stain is this? The green stain? It's green and there is black. Okay. So what stain do you think it is, Prayas? All right. Let's ask Sarangi, what stain is this? One on the left is obviously an H&E. Yes. And the one on the right is what, Sarangi? Something that has a green counter stain and it's black.
TMS.
TMS. Very good. So what is the black in a GMS? In fact, what is black in any stain that we use? Silver. Excellent. Yes, Sarangi. So silver has been deposited. Now, Sarangi, you want to help Prayas and say what you are actually seeing? What are you seeing? What are all these very big things? You think that this has been photographed under an electron microscope? Yeah, it's huge, isn't it?
Yes, ma'am.
So what are these things then? That have these very large, and inside you have smaller structures.
There are
yes,
some kind of parasite.
Parasite. Okay, that's what. Do we use the GMS stain by and large for parasites? Or do we use the GMS stain for
Fungus.
fungal infections? Wow, very good. So which fungus do you think this is? Huh? What do these look like? These big structures that you see?
Sporangium.
Somebody said something. Who said that,
Sporangium.
Monica?
Sporangium.
Sporangia. Yes. So inside, you know that fungi have spores. So you see all these fungal organisms, and there are big sporangia, and inside them you have the spores of the fungus. In smaller capsulated sporangia, and you have big sporangia, you have small sporangia, and you see these spores. So what is this organism? It's not a parasite. Yes, Monica. What is it? You rightly called it a sporangium. So rhinosporidiosis. Yes, and rhinosporidiosis normally occurs where, Prayas?
Nasal cavity.
Nasal cavity. And this sometimes you can get it at some other parts of the body where somebody who's probably been picking his or her nose then transfers this to the soft tissues at other sites, and it is not at all so rare in countries where you have a lot of rhinosporidiosis to come across extranasal rhinosporidiosis. So this is rhinosporidiosis in bone. Okay. So there you are. It happens, and it also looks like it is a malignant tumor because multiple bones are destroyed, but this is rhinosporidiosis. Very good. Excellent, Prayas. All right, now come on. Let's do the next case that you have seen. Who is going to do this now? Sarangi, you want to try?
Yes, ma'am.
Very good. Come on.
A 62-year-old male, pain in the left knee while walking. Needle core biopsy was done. Following the diagnosis, the lower end of the femur had an en bloc resection.
Right, so I shared the needle core biopsy. First of all, the X-rays, right? Come on now, Sarangi, what are you seeing?
An eccentric lesion on the medial condyle of the femur.
We discussed how we describe lesions in bone. Yes, Sarangi. So we said we need to know which bone, we need to know where in the bone, and when we say where in the bone, it's not in the middle of the bone and upper and lower. What we need to say is
epiphysis is involved.
Okay, so this is epiphysis, all right. Oh, very good. We need to also say whether this is a mature skeleton, this is an immature skeleton. We said all this, right, Sarangi? So there is a system by which this is when we are describing histopathology, we have a system when we're describing bone. So come on now, don't sort of do this in an unsystematic, helter-skelter kind of fashion. Come on.
On this image we see a lytic lesion present on the distal end of femur, which is the femur appears to be the skeleton appears to be mature,
Yes.
and epiphyseal to metaphyseal lesion, we can say that it is extending up to the metaphysis.
All right, so it is reached, it is in the epiphysis, it's actually reached the condylar surface. And once again, you see that the cartilage, which you should expect, which is lining the lower end of the femur and the upper end of the tibia, because that is the joint space, you should see cartilage, but you're not seeing cartilage. Why? Because this is a plain X-ray, right? So the cartilage is radiolucent, that's what we mean. So it doesn't stop the X-rays from passing, whereas bone does. So you are seeing this, very good. So it looks as if there is a metaphyseal component to this this lesion as well. You can see this when you see it in a lateral view. Very good. And anything else you want to say? Is it just one nice bubble, or do you see some trabeculations in this lesion?
Trabeculations are seen.
There are trabeculations within this lesion. Very good. And what is the zone of transition? We need to talk about the zone of transition. Isn't that right, Sarangi?
Yes, ma'am.
So is the zone of transition, and you see the zone of transition here? Yeah, sharp zone of transition.
Yes, ma'am.
There seems to be that. I mean, there may be something that has in the posterior aspect of the femur, there may be a small soft tissue extension. Very difficult to say over here, but with the transition between the bone and the lesion is very sharp. You can see that. So there is something that looks almost like, at least in this left-hand side X-ray, you might even say that there is a soap bubble appearance. There is a soap bubble appearance.
Yeah.
You can also see it because that's what trabeculations within the lesion gives this appearance of a soap bubble appearance. All right, so this is a mature skeleton. It has this soap bubble-like appearance. It's a narrow zone of transition. It has reached the condyle, and it has reached almost the articular surface of the condyle, and it has it has a soap bubble appearance. So what would your first impression be on an X-ray, Sarangi? You've heard the soap bubble business in your life before? And when somebody says soap bubble appearance in the epiphysis of a long bone in a mature skeleton, what would you think of?
GCT.
That's very easy to answer. Yeah, I'm eager to answer. Yes, Sarangi?
GCT.
Yeah, what is GCT? Giant cell tumor?
Giant cell tumor.
So please do not use short forms, because a gynecologist will, or a urologist will think it is a germ cell tumor, and if you're an orthopedic surgeon, you will think it is a giant cell tumor. So giant cell tumor, I think that's what. So let us see now. This was a needle core biopsy. It is a needle core biopsy. Now come on, Sarangi. You think this is a giant cell tumor?
No, here we can't see the osteoclastic giant cells are not visible on this slide. But
Can it still be a giant cell tumor? What do you see?
it is a cellular.
Okay.
It is cellular. The slide is.
What do you see when you look at it? See, you're expecting a giant cell tumor, Sarangi, okay? And suddenly when you look at you pick up the, your slide and put it under your microscope, what do you see? I mean, it's there. You don't have to.
Cartilaginous area.
So you are seeing something that looks, there is a matrix forming lesion. Yes or no? Do you expect a giant cell tumor to form a matrix?
No, ma'am.
No. So now that we've used this word, Sarangi, matrix. What is matrix? Matrix, whichever way you want to pronounce it. What is the meaning of the word matrix or matrix?
Cement kind.
The supporting
Is that-
structure.
No, you define to me what is matrix or matrix.
Connecting substance.
Connecting substance. Does it always have to connect something?
Or forming like it can be.
Is bone a matrix? Bone.
Yes, ma'am.
Bone is a matrix, right? Yes. Cartilage, is it a matrix?
Yes, ma'am.
Yes. What other matrices do you know? Tell me. What other matrices do you know?
Connective tissue stroma.
No, connective tissue stroma is not a matrix. What is a matrix?
Collagen.
Collagen is a matrix. Very good. Anything else is matrix?
Fibroblast.
Fibroblast is a matrix. Monica, so you have not understood. You said it is connective tissue. That's why I'm asking what is a matrix. Many things connect many things, but what is a matrix?
Intercellular substance.
Intercellular substance. Excellent. Who's that, Zara?
Yes, ma'am.
Yes. So now please, we need to be able to define something so that we have no confusion in our heads. Okay. So number one, it is intercellular, which means it is extracellular. Yes, it is an extracellular substance. So it's a substance. It is not a cell. It is extracellular substance, which is in the stroma. Can you tell me why we have to say that it is in the stroma? Can you get extracellular substance that is not in the stroma? Can anybody tell me of extracellular substance which is not in the stroma? Or else you're always putting up your hand. Tell me. Amyloid, it is in the stroma. Amyloid is not. It is in the stroma, right? Except that we don't call amyloid by and large a matrix. So if I were asked that question and somebody asked me about extracellular substance and in the stroma, then I would ask myself, what other extracellular spaces are there? Can anybody tell me about an extracellular space that is not stroma? And maybe somebody will say it in the chat box. Yes, Prayas. Hema, can you think of an extracellular space that is not stroma? I'll give you a hint. It's often round and it's a space. And it is not stroma.
Synovial fluid.
Synovial fluid. Yes, okay. But it's not a matrix, no, because it's fluid. Is there any other thing that is in extracellular space? Come on, you don't have
Eye, ma'am, in the eye.
In the eye, yes, you have the vitreous.
Vitreous cavity.
Yes, and you have all your ducts. You have glands and you have ducts. Don't you have material that is present over here? Aren't they secretions? Yes, that's also an extracellular space. Yes or no?
Yes.
So remember, there are extracellular spaces that are not stromal spaces. And why do we have to make this definition so stringent? Because you can have material that is inside a space that looks like a lumen, but is not a true lumen. It is actually an extracellular space. And do you know which tumor you have a lot of confusion with? where you have a tumor and you have spaces that look like they are glands, but they are not glands. Okay, in fact, we use the oid term. That is an adenoid cystic carcinoma. Though that space in which you get that pink or light blue material, that is not a gland. That is actually stroma. And those cells are myoepithelial cells which are secreting this material, which is a matrix, that is basement membrane matrix, which is a kind of collagen, into, sometimes it is very mixoid, into a space which is not a gland. Okay, it is the stroma. Because if you bother to go and look at, look inside those spaces, you will often find blood vessels as well as sometimes even fibroblasts. So that's why this matrix is an extracellular substance which we have got that is present in the stroma over here. Very good. So who was doing this now? I think it was Sarangi, right? Sarangi, were you describing this?
Yes, ma'am.
All right. So now, so you see something, and it is mixochondroid. You can see that. You can't make out classical cartilage, hyaline cartilage, and yet you can see that it is blue, and it is a mixochondroid matrix. So it is a tumor. You can make out that it is a tumor, yes or no?
Yes, ma'am.
Yes, it's very cellular. It is a tumor, and it has a mixochondroid matrix. So straight away, you thought you were dealing with a giant cell tumor, and it is not a giant cell tumor. Excellent. So, and you also see areas of calcification, right?
Yes.
So let's go and see this at higher power. Come on, Sarangi. What are you seeing in high power over here?
Here, the chondromyxoid matrix is seen, and some calcified areas, and chondrocytes are present inside the lacunae.
Okay, so you see the cellular component of this tumor appears to be chondrocytes. Yes. Why do you think that they look like chondrocytes?
Because they are present inside the lacunae, and
Excellent. Yes, they're sitting in spaces that look like lacunae. And when you see lacunae inside a chondromyxoid matrix, you have very little doubt that what you're looking at are chondrocytes. Is there anything else that you see besides this chondromyxoid matrix? Is there anything else that you see somewhere at the top here and all of this? Something that's a matrix, but it is not chondromyxoid. Is there any other matrix that you can see? There's calcification, and that calcification seems to be sitting in that other matrix. Can you see it or you don't?
Yes, ma'am.
What color is that matrix?
Purple.
Very eosinophilic. Yes. So you also see a eosinophilic matrix that is ramifying between inside the chondromyxoid stroma. Okay. And except that you're not seeing too many cells that seem to be around it. Almost all the cells are sitting in lacunae in this chondromyxoid matrix. Excellent. You see this at high power. Now, you want to say anything more about these cells, please?
Ma'am, each cell, there is size and shape variation with each cell.
Okay, very good.
And
that's excellent. Yes, there is a size and shape variation of the cell. And what do you mean by the cell when you mention the cell, Sarangi? What are we describing? Size and shape variation of what? The cytoplasm, the nucleus, the shape, what?
Nuclear variation.
So nuclear. And you don't think that the size and shape of the cell body is varying? Can you see a cell body?
Yes, ma'am. Both are, there is variation in both.
Yes. So you are seeing the cells which are eosinophilic, have a eosinophilic cytoplasm, wherever you can see them, yes?
Yes, ma'am.
And then they vary in size. You can see some cells are small, some cells are larger, intermediate between large and small. And then some of them have a very defined cytoplasmic border that you can see over here, yes?
Yes, ma'am.
Many of them, as you rightly described before, have a halo around them, so they are sitting in lacunae. And now, after you have described that, you want to describe the nuclei. So come on, tell me about the nuclei.
The nuclei is small, round, hyperchromatic, and pleomorphic.
Sarangi, are you looking carefully at the nuclei? I will ask each of your friends who are there whether they agree with you. These are small, round, and hyperchromatic. The only thing I will agree with you is hyperchromatic. What is small? What is round about these nuclei? They vary from really small and dense to. Oh, of course, many of these have got a fair degree of pleomorphism. Okay, they're not highly pleomorphic, but they are. And what would you say is the shape of these nuclei? They're not round. What are they, Sarangi? What are the shapes of these nuclei? What have you got here where you can see my cursor? What have you got here? Elongated, I'm going to call this elongated. Eccentric has got nothing to do with the shape of the nucleus. What is eccentric? Who said eccentric?
Crescent.
No, who said it? Who said it?
Crescent shape.
Crescent, okay, yes. So it is, there is a nucleus which is crescentic over here. What about this nucleus? This is also looking crescentic. There are other nuclei which are irregular in shape. See, there's another crescentic nucleus. So many of these nuclei, some, yes, are round. So they are varying. Some are oval. There is very definitely a density to these nuclei, but there are many nuclei that are crescentic. There's one, there's another one, there's another one, and others are irregular. Some of them are actually spindle in shape. So there is a variation in nuclear shapes, and some of them are crescentic. All right. So we gave some diagnosis, and they resected the lower end of this femur, and you can see this. You'd like to describe this, please, Sarangi?
On the grossly, we can see that a very large hemorrhagic area is present on the distal end of the femur, and the lesion is seen on the medial side, and on the upper part, the normal cortex and marrow of the bone is seen.
All right, but what you're seeing is that it is sitting squarely within the epiphysis, no?
Yes, ma'am.
It's not at all in the diaphysis, although it looked when the projection was made on the X-ray, which you can see here, we thought that it might have been metaphyseal, but it is not. This thing is sitting squarely in the epiphysis, and it has got many cystic spaces that are filled with blood. Yes, and you're right. It is on the medial side of this femur. Excellent. So, what are our observations on radiology and gross exam? You had a radiolucency in the metaepiphysis, but now when we looked at the gross examination, this was an ill-defined lesion. It looked very well defined to us when we saw it on an X-ray, which was reaching up to the articular cartilage. You can see that, yeah, because the articular cartilage goes all the way around. That is the condyle, and there are blood-filled spaces. There was spottic sclerosis, which we saw on the X-ray. Okay, good, Sarangi. So come on now, describe.
Here we can see the.
Is it similar to what you saw on the needle core biopsy, Sarangi?
No, ma'am. Your extensive cartilaginous tissue is more.
Cartilaginous tissue is more. All right. So you want to, sort of ask for annotation and show me where the cartilaginous tissue is more. Very good. Now show me, where is this cartilaginous tissue that is more? Just outline the cartilaginous tissue that is more.
This part, this whole part.
Take a thicker pen. You see there's a pen over here? Yeah. Take that thick pen, you've taken a line. Take a pen and outline whatever you think is the cartilaginous tissue which you think is more. Okay? When I mean outline, shall I outline it for you? I think you mean this, right?
Yes, ma'am.
Yes. So all this from there to there, according to you, cartilaginous tissue is more. All right. So what do you think this cartilaginous tissue is, Sarangi? What is it?
Chondroid.
What is this cartilaginous tissue?
Chondroid.
Chondroid matrix. Of course, it is chondroid matrix. That's why you called it cartilage. Okay.
Yes, ma'am.
Do you remember what the cartilage looked like in the previous thing?
Ma'am, it appears more bluish.
No. Yes. So now this, just take a good hard look at this. All right.
Yes, ma'am.
Looking, Sarangi. Everybody's looking at it, because if Sarangi cannot articulate what she thinks, then others have to. Okay. Now Sarangi said that all of this, which I am showing you with my cursor, there is more cartilage, much more than there was in the needle core biopsy, which Sarangi we called a tumor, right?
Ma'am, bony, osteoid.
Osteoid. No. Now we're talking about the cartilage, Sarangi. Okay. All right. Let me ask somebody else over there. Manasi.
Yes, ma'am.
Now she said that she's seeing a lot more cartilage, right? So do you agree with her that you're seeing a lot more cartilage in this tumor?
Ma'am, I feel this is the bone cortex
You
of
think
the
this is
bone.
bone? You think this is the cortex of the bone?
Yes,
Manasi?
ma'am.
All
These are
right.
the trabeculae which are
The
inside.
trabeculae. Now let me ask myself to let me get myself annotation so that I know what you guys are talking about. You think that all of this, let me take another color so that there is no, all this that we outlined is articular cartilage. Is that what you think? Yes, that's what you think? Yes, Mansi? All right, Mansi thinks that. It's fine. I mean, that's, you don't think that this is part of the tumor. You think that this is part of what? What did you say, Mansi? Of cortical bone. Yeah, okay. Monica, what do you think? Is this or is this not part of the tumor?
This is part of the bone and the
Part of the tumor?
No, this is part of the. This is a bone. Not
This is bone. Okay, Monica thinks it is bone. Mansi thinks it is bone. I think Sarangi thought it was a lot more cartilage in the tumor. Who have we got over here? Hema, tell me.
It is cartilage, more
It
cartilage.
is cartilage. All right, very good. You agree with with the Mansi that with Sarangi that this is cartilage. Now, what cartilage is this? Part of the tumor?
Part of the tumor, ma'am.
Part of the tumor. All right. So you are on Sarangi's slide. Now we come to Zara. Zara, before I get to Prayas.
Yes, ma'am. Ma'am, I think it's the hyaline cartilage, that is the cartilage cap, cartilaginous cap,
Of what?
from which the chondrocytes are permeating into the bone.
Chondrocytes are coming into the bone. So what? This is the epiphyseal cartilage according to you, Zara, which makes bone.
Ma'am, yes, ma'am, the cartilaginous cap.
Cartilaginous cap. What is a cartilaginous cap? Can you explain to us, Zara? What cap? Are we talking about an enchondroma? An osteochondroma which grows out of the bone and it has got a cartilaginous cap? Is that what you're talking about? We never saw any such thing here. All right. Do you want to see the gross appearance of this lesion? It's right there. The gross appearance. 1 second. It's thinking about moving. It should. Yeah. Where is your cartilaginous cap? Ask for annotation and show it to me. You know how to ask for annotation, Zara?
Yes, ma'am.
Very good. Come on.
Ma'am, maybe this area around here.
This. Where? All right. So what is that? What cartilaginous cap is that, please, Zara? What is it?
Ma'am,
I can see the beautiful white cartilage over there.
epiphyseal.
So now Zara thinks that this is epiphyseal cartilage. All right, Prayas. You are the last person now. I can see cartilage. I can see cartilage. Beautiful here. White cartilage. Cartilage looks white, right? Yes. So Prayas, what cartilage are we seeing? This cartilage, which has been outlined by Zara and me. What cartilage is that? She thinks it's epiphyseal cartilage. What do you think? What do you think, Prayas?
That's not my practice.
That is not epiphyseal cartilage. Excellent. So what cartilage is it? Prayas? Can you see the left-hand side of the screen, Prayas?
Yes,
What does it say? Below the red line, all of you are looking
Articular
at it.
cartilage.
So is it so difficult to know that this is articular cartilage? It says that there is an ill-defined lesion reaching up to the articular cartilage. And people are talking about this being bone. People are saying that it is cartilage that is in the tumor. Somebody is calling this epiphyseal cartilage. Somebody is calling it a cartilaginous cap. All right. This, what you saw over there, is articular cartilage. Absolutely normal articular cartilage. Okay, Sarangi, do you agree that this is normal articular cartilage?
Yes, ma'am.
Yes. So what I am trying to say is that, why normality is something that you need to understand. This is not part of a tumor. This is not bone. It cannot be bone. It has got all these chondrocytes with very almost pycnotic nuclei sitting inside lacunae. What other information do you need to call this articular cartilage? And I am telling you, I know why you called it, part of the tumor, or you didn't recognize it as articular cartilage. Because why, Sarangi? Because
The color there it is more bluish, and here it is more eosinophilic.
yes, because in my mind, cartilage has to be blue, and if it is not blue, then it is not cartilage. Okay, but that's not how we make diagnoses. Otherwise, it depends on. Do you realize that this must have been decalcified? Whereas whatever we did before, do you think that was decalcified? And the answer is no. The needle core biopsy was not decalcified. Okay, this has been decalcified, and when you decalcify anything, the pH changes, and you may not get the same tinctorial hues. And what is the meaning of tinctorial hues, Zara? What is the meaning of a tinct? Tinct means color. Okay, you may not get the same color depending upon what you're using hematoxylin and eosin, but to get the ideal hematoxylin and eosin colors, there should be the ideal pH, which changes when you have to decalcify something. All right, so come on now, Sarangi, you're seeing articular cartilage, which tells you that what we noticed on Gross was absolutely right. There is a lesion. It is a tumor. It has reached the articular cartilage, but it has not breached the articular cartilage. All right, and you're seeing a lot of calcified structures over here. Okay, you can see them. They are trabeculae. You can call them reams of something that is calcified. Right, and what you saw there was looking more blue. Here it is looking quite pink. Okay? And it's the only reason that it is doing that. Although, Sarangi, you told me when you described that needle core biopsy, you recognized those cells as being cartilage. Why?
Due to chondrocytes.
Yes, you recognize them as chondrocytes, but why did you recognize them as chondrocytes?
They have halo around them. Clear.
Yes, they had a halo around them. Okay, and they were sitting in that blue extracellular matrix. Here, the matrix has turned pink, and we know that this is probably blue. Why? But it is turned pink because my cartilage that is normal, which would be blue, is now showing up as pink. So all this stuff that is pink over here is probably blue because it has got halos around these the cells that are within it. Now, do you see anything else, Sarangi, that you want to remark on?
Giant cells.
Giant cells, okay. But what is happening in the whole of this? We're only talking about this, but what about all this? What are the cells like? What are the cells like?
There is increased number of cells have increased.
Number of cells have not increased. This is a very cellular part of the tumor, right?
Yes.
It's hugely cellular. And not only is it hugely cellular, there is a good deal of pleomorphism over here. Certainly, this is not a monomorphic tumor with just a mild variation in nuclear shape and size, as well as cytoplasmic shape and size, right? So it has a chondroid look, but in this, you are seeing a far more pink matrix. Not only that, what are you seeing here now? You saw all this before because you must have seen your all these slides. Okay, you see that there are two colors here. There is a grayish thing which you would accept more as being cartilage, and here you're seeing pink stuff which you would otherwise extracellular matrix that you would otherwise recognize as osteoid. No, that is this funny looking pink material which looks like osteoid, and yet the cells that are sitting in them in this osteoid are
Chondrocytes.
Chondrocytes. Yes, they do not have the appearance of osteocytes. They have the classical appearance of chondrocytes sitting in a vacuole. All right, so there. Now look at them in high power and see. And the cell bodies are eosinophilic. Most of them have shrunk away from their vacuoles that are lining them. Some of them give you this appearance that they may be clear cells. Actually, they're not. They are cells which look clear because the nucleus seems to be sitting in a vacuole. But around each of these nuclei, you actually see a pink cytoplasmic body. Does everybody appreciate that? Can you appreciate it, Sarangi?
Yes, ma'am.
All right, very good. And you've got this calcification that looks as if it is calcified osteoid, except that in that you are seeing these cells with vacuoles which you would otherwise recognize as being chondrocytes. Now, do you think that this is something that looks very benign, or what?
It does not look benign because
It does not look benign. Very good. Why?
very much pleomorphism of nuclei and cells.
There is nuclear pleomorphism. You see binucleation also over here if you look at the bottom. And you may not appreciate a lot of mitoses, but this has got too much nuclear variation for it to look absolutely benign. All right. There you are at even higher part. Okay, and you see that there's vacuolation in some of these cells. So some of them may be actually clear cells, or they may have just sort of the cell body has come away from the vacuole in which it is sitting. Okay? Right. So this is chondrocyte. Now what do you see here?
This large hemorrhagic area surrounded by cells.
Large hemorrhagic area. Now, see, somebody else also said, like Mansi said, I see hemorrhage. So do you think that this is hemorrhage? And if so, who made this hemorrhage? Was it a hemorrhage inside this tumor, or did the surgeon make this hemorrhage? And was this hemorrhage caused by our previous biopsy, or what? Would you call this hemorrhage? All right, now Sarangi thinks it's hemorrhage. Zara, what do you think? Hemorrhage or no hemorrhage?
No, ma'am.
What, Zara?
No, ma'am.
Hemorrhage? No hemorrhage?
No, ma'am.
No, ma'am. So if it's not hemorrage, what is it? Now you can't say no, ma'am, and not tell me if it's not hemorrhage, what is it? All right, while you're thinking, Hema, do you think it's hemorrhage or no hemorrhage?
Ma'am, these are blood cell spaces that are
These are blood-filled spaces.
grossly also
Yes.
in the tumor, ma'am.
Excellent. Because now we have to understand what is hemorrhage, right? Hemorrhage is extravasation outside of a space. Okay, so you can't just call anything hemorrhage. This is so well known in bone tumors. What do we call these spaces? What do we call these spaces in bone tumors? Yes, Prayas? Prayas, what do you call spaces that are full of blood when they occur in bone tumors?
Aneurysmal bone cyst.
Aneurysmal bone cyst.
Aneurysmally dilated spaces. Okay? If they are benign, that means the cells lining them are benign. We call that aneurysmal bone cyst. If the cells that are lining them are malignant, what do we call them? Telangiectasia, right? In any case, an aneurysmal bone cyst is a telangiectatic, has got telangiectatic spaces. But there's a name for it when it is benign, and we call them aneurysmal bone cyst. When this sort of an aneurysmally bone cyst-like area occurs in an osteosarcoma, you call it a telangiectatic osteosarcoma. Yes or no?
Yes.
Yeah, so we use different terms so that we understand what we are actually talking about. All right, very good, but these are aneurysmally dilated spaces. Never mind whether you want to call that, telangiectatic if it is malignant or otherwise. Very good. So now, Come on, Sarangi, what was your diagnosis? These are all the observations that we have made over here. Yes?
It can be chondrosarcoma.
It could be a chondrosarcoma. All right. So if it is a chondrosarcoma, what kind of chondrosarcoma? What kind of chondrosarcoma? Where do you get chondrosarcomas, Sarangi? You saw this, right? And you must have discussed it. You must have read it. Where do you get chondrosarcomas?
In the ends of the long bones.
At the ends of the long bones, is that where you get chondrosarcomas? Sarangi, where do you get them normally?
Metaphysis.
Yes, Prayas, where do you get chondrosarcomas?
Metaphysis of long bones.
In the metaphysis, in the diaphysis of long bones. No, that's wherever you get enchondromas, you will get chondrosarcomas. You do not get chondrosarcomas in the epiphysis, except, so it's very rare. If you get a chondrosarcoma in the epiphysis, it must be exceedingly rare. So now come on, Sarangi, are you still going to call this a chondrosarcoma? Yes? And the answer is yes. It is a chondrosarcoma, but it is a particular kind of chondrosarcoma. So which kind of chondrosarcoma? This is a clear chondrosarcoma. It's the only kind of chondrosarcoma that arises in the epiphysis of a long bone. All right. It can be mistaken for a chondroblastoma. Why? Because it looks like a chondroblastoma on X-rays, and because it has a chondroid matrix, somebody might mistake it for a chondroblastoma, and sometimes a chondroblastoma is mistaken for a clear cell chondrosarcoma. But we have no difficulty over here. Why? Because it was so obviously malignant. Okay, and this is just something about a clear cell chondrosarcoma. It looks malignant, but it has low-grade behavior. Yeah, its low-grade behavior is attested to by the fact that it has not got an aggressive radiological appearance. Yeah, do you agree, Sarangi?
Yes, ma'am.
Its radiological appearance was not aggressive.
Yes.
Why are we saying that it is not aggressive? What is the non-aggressive radiology that we saw, Sarangi? What is the non-aggressive radiology? You saw what the radiology was, right? Right. Yes, anybody would like to help Sarangi?
Circumscription.
Demarcation.
And a very narrow zone of transition means that it was so well circumscribed that you could draw a line between it and the normal bone. Okay, that is what is the meaning of something that is non-aggressive. If you have a wide zone of transition, it means that this tumor is diffusing out into the surrounding bone. So, Sarangi, I hope you will remember this now, that a narrow zone of transition means that it is
Not,
what does it mean, Sarangi?
It's not aggressive.
It is non-aggressive. Non-aggressive does not always mean benign. All right. Here is a tumor that looks non-aggressive, yet it is a sarcoma. But because it is growing so slowly, see, low-grade behavior. It is like, you probably learned in your second MBBS. I hope you don't believe it when you came to post-graduation in pathology. What was the distinction between benign and malignant tumors? We used to write benign and malignant. And then we had a left-hand side, we had some rows, right? So what were the different features between benign and malignant as far as the growth was concerned? Yes, somebody remember?
Well-defined.
Well circumscribed and or encapsulated. Why is it so in benign tumors or slow-growing tumors? We expect all benign tumors to be slow-growing, right? And that's why they have time to build a capsule or a good circumscription around them. They erode rather than infiltrate. And you saw that so beautifully in that cartilage. Did you see that cartilage? It's not infiltrated. This cartilage is beautifully intact, although now you have a tumor that is an obviously malignant tumor. You got that, Sarangi? All of you? Are there any questions that anybody wants to ask or in the chat box or whatever? All right. This, all cartilage tends to be S100 protein positive. And here it is showing you this very good S100 protein. Prayas, where is the S100 protein being expressed? You see this? This is positive for S100 protein.
Yes.
So where is the S100 protein being expressed? You said yes, ma'am. So where is it being expressed? How do you know that? Sorry? Where is it being expressed?
The chondrocytes.
Oh, thank you. But where in the chondrocytes, Prayas?
Nuclear positivity.
Nuclear positivity. So that's something you have to remember about S100 protein. S100 protein should be, if it has to be judged as being positive, has to be expressed in the nucleus. There are very, very few tumors where you would accept S100 protein in the cytoplasm as being positive. And it may be tumors, it may be any other cell, but that is histiocytes. Histiocytes express S100 protein within the cytoplasm, and you can take that as positive. Okay. Otherwise, you do not accept S100 protein positivity in any cell, okay? Including some histiocytes, unless it is in the nucleus. Very good. So this is clear cell chondrosarcoma.
Ma'am, one question in this.
Yes.
Ma'am, someone has asked that is there any ISC marker to differentiate clear cell chondrosarcoma from chondroblastoma?
Well, there are IHC markers, yes, which I think is important, and we'll answer the question in a little while. All right? Yeah. So if they have a little patience, they will find the answer to that question. All right. Come on now, who's going to take this? Prayas, come on. We've had all the ladies. We've had ladies answering now. Come on, Prayas.
It's a 27-year-old female with pain in the right knee and the paraffin block of an open biopsy were received for the review.
Excellent. Okay. So now describe this, Prayas.
As the X-ray picture shows, this is the.
Now you know how to describe Prayas. Chalo.
Yes, the X-ray picture shows the epiphyseal end of the femur.
The what end of the femur? What end of the femur is this? Upper end, lower end?
Ma'am, lower end.
Lower end of the femur. Very good. Yes.
Epiphyseal portion. We can see.
I can see everything. I can see the metaphysis. I can see the shaft. I can see many things. So you are saying that you're seeing the lower end of the femur, which shows what? It shows a.
In the epiphyseal end of the.
It shows something in the epiphysis of the tumor. So what is it showing? What is it showing?
Some radiolucent light.
Very good. So there is a radiolucent lesion. In other words, in a bone, when you see a radiolucent lesion, you call it lytic. Yes. So there is a lytic radiolucent lesion where?
In the epiphysis of the lower end of the.
In the epiphysis at the lower end of the femur. Fantastic. Excellent, Prayas. Then, what do you think this is? Do you think that this is a mature or an immature skeleton?
Yes, ma'am. Ma'am, this is a mature skeleton.
A mature skeleton. Okay. So in the epiphysis of a mature skeleton. Okay. Then, What else have you to describe? Come on, Prayas. We just did something in the previous. What do you have to say about the lesion? I know it is lytic, but now I have to know what's its relationship to the.
As it is a ma'am, it's a circumscribed lesion.
Very good. Excellent. It is circumscribed and it has
Encapsulated.
No, it can. You cannot talk about encapsulation in a bone tumor or a bone lesion, Prayas. It has a narrow zone of transition.
Sorry,
Yes, that's what I meant to say. So it has a narrow zone of transition. You see that you can mentally put your finger around it to mark the demarcation of this lesion. Okay. So now, what is your diagnosis, Prayas, on this? Does it have internal tuberculations? You saw the case that we just finished. Okay, it has internal tuberculations, right? That means there was septi inside. That is what a tuberculum is. There are septi inside. Are there septi here?
No, ma'am.
No, excellent. There are no septi. So it is like almost like a completely radiolucent, and some people would look at it and say that this is a cyst because I can't see anything in it. Okay, but there are no such things as cysts, no? Because I mean, yes, there are such things as cysts, but anything that is not forming bone would look like this. So it doesn't have to be cystic. It's just some lesion that is there, either cystic or solid, but it is not forming bone. So it is allowing X-rays to go through this. Very good. So now, what would be your possible differential diagnosis? It's unlikely to be a giant cell tumor, right?
Yes, ma'am.
Why? Because it's not got internal septations. So what is the other tumor that occurs in the epiphysis in a young individual, in the femur, very commonly in the femur, and that has this kind of appearance? Anybody? Because all of you have seen this, shown it in your departments, gone to the X-ray department. Anybody saying anything in the chat box, Saloma? Chondroblastoma. No, chondromyxoid fibroma doesn't occur in the epiphysis. Chondromyxoid fibroma occurs in the diaphysis. Okay, so we're talking about the epiphysis. So bone cyst does not occur in the epiphysis. Aneurysmal bone cyst does not occur in the epiphysis. Giant cell tumor does, but this is not tuberculated. Okay, chondromyxoid fibroma occurs in the diaphysis, and so we are left with one tumor that looks absolutely as if it is like a chondroblastoma because 27-year-old epiphysis, narrow zone of transition, everything. All right, now. And that's the same thing. You know, here you have got MR, and you can see it black, you can see it white, whatever. And that's the MR, and it shows you that beautiful circumscription. All right. Now, come on, Prayas. You think it was cystic? The answer is?
Yes.
It was cystic. This is what you're seeing here is cystic?
No, ma'am.
No, it's not. Okay, so what do you see? You see something that is solid, right?
Yes, ma'am. The biopsy is showing hypercellularity, ma'am.
Okay. It's showing hypercellularity. But please tell me what you are seeing at low power. No. You see what? You see hypercellularity. That doesn't mean anything to me. Prayas, you know something, you may not have attended any of my classes before, I don't know, but you know when I say, what is a good description? A good description is one which, if you make that description to me and I have lost my eyesight, I would still be able to make a diagnosis, okay? Because I have seen enough tumors, enough lesions, so if you give me a good description, I would be able to make the diagnosis. Now when you're saying, I'm seeing hypercellularity, it's not a good description. So tell me what you see. I am blind. Now you tell me. What are you seeing at low power? You start. Ma'am, I am seeing. What? What are these blue things and big things, Prayas? What do you think is that blue stuff that you are seeing?
Cartilage.
So there is cartilage. Okay, so you see fragments, very irregular fragments of cartilage, and then fragments of a very cellular. Yes, it must be a tumor because nothing else can do this. A very cellular tumor. Okay, in which you cannot make out at this far whether there is a matrix or not. That you can see cartilage without a doubt is without a doubt, and some of this cartilage is actually sitting within this very cellular tumor. You agree, Prayas? Yes. Okay. Right. Now let's go to the cellular areas. And what do the cellular areas show you?
It shows multinucleated giant cells as mononuclear stromal cells are also.
Excellent, very good. Yes.
In behind.
Anything else you see?
Calcification.
Apart from giant cells and mononuclear stromal cells. What's the answer to that question? Yes or no?
Spindle cells.
Spindle cells. Okay, but they're all looking the same, right? They may be a little fascicle here, but there are only two things. This is the cellularity in this section is composed just of two things. You have got sheets of mononuclear cells with each cytoplasmic border so well defined. It's like they're like boxes. Can you see them, Prayas?
Yes.
Yes. And they are boxes and they have nuclei. The nuclei are oval, some of them are round, and each nucleus, you can even see it at this far, has got a nucleolus. And then interspersed within the sheets, Prayas, you are seeing osteoclast-like giant cells. Now, what would you say about the distribution of these osteoclast-like giant cells within the sheets of these mononuclear cells? Are they regularly distributed? Are they irregularly distributed?
Seems to be like regularly distributed now.
Why do you think that they're regularly distributed? What is the meaning of regular? What do you mean by regular? Perhaps you have to tell me, no? What is regular? Because you said it is regular. That means for every section of the stromal cells, you will have 1, 2, 3, whatever giant cells, and that pattern is repeated everywhere. Is that pattern repeated everywhere? No. You have areas like the top left-hand corner, the bottom right-hand corner, which are devoid, no?
Irregular.
So then it is irregularly distributed osteoclast-like giant cells. Very good. Now what do we see over here? So when you saw that, and you had Prayas, and you saw the X-ray, what came to your mind? Hey, maybe this was a giant cell tumor. Yes, and it was not showing tuberculation because it looked so benign. But very soon you move to another area, and what do you see? Come on,
Cartilage.
You see
Cartilaginous background.
Yes. Everything is cartilaginous? No. So you still see those stromal cells here. You can see them to the right, and you see cartilage. And that cartilage has got what? Is it hyaline cartilage? Is it a bit of the like we saw in the first case? Do you think it's a portion of the articular cartilage that has come out over here? Yes, Prayas? You think? No. The answer is no. It is not the articular cartilage. Why do we say it's not the articular cartilage?
Ma'am,
Because?
color, ma'am, is not that dark blue.
Because of the color. Now come on, Prayas. Now.
Ma'am, because the mineralization takes place.
Because of mineralization. Come on, Prayas. Come on now. Hema, why is this not articular cartilage?
The color is not hyaline cartilage.
Again, you are going on about color. Color, I told you, is very, very dependent upon what?
Calcification.
Well, if there is calcification or there is pH. Okay. So now please don't tell me why do you think that this is cartilage? Come on. Prayas, please tell Hema why this is cartilage. Because it's blue? No. Why is this cartilage?
Chondrocytes.
What do you call them chondrocytes?
Lacunae is there in
Because
chondrocytes.
there are lacunae. So this is cartilage. Now I'm asking you the question. We have agreed that this is cartilage, but why is it not hyaline cartilage? Monica. Come on, Monica.
No clear zone of
Because
transition.
there's no clear zone. Oh dear. Zara, is this not hyaline? Is this not articular cartilage?
Ma'am, because it is a part of the tumor.
Because it's a part of the tumor. How do you know it's part of the tumor? Zara, why is this not articular cartilage? All right, Mansi.
Ma'am, I can
See
see
you there?
Yes, ma'am. Ma'am, these
Because?
stroma cells are
Because all articular cartilage is hyaline cartilage. Yes. And it is made up of what is normal hyaline cartilage like, Sarangi? You saw it in your case in the last case that we discussed. So what is hyaline cartilage like, Sarangi?
It is in that chondrocytes are present which are of same.
Not only are they same, but they have got almost pycnotic-like nuclei, right? Yes. Look at this. There is variation in size, shape, nuclear, density, everything. Now you tell me, how can this be normal articular cartilage? It is not. In fact, it has got so much variation, which is now beginning to resemble the variation that you're seeing outside of this cartilaginous area. Yes, you can see that. Okay. In the previous, you saw more or less monomorphic looking cells. Okay. There was not much variation. We said that in the stromal cells, but now comes the cartilage. This is varying in how these cells look like. There is huge cellular variation, and you're beginning to see the so-called stromal cells, which are associated with these osteoclastic cells, which are also varying. So now this is not a giant cell tumor, because giant cell tumors do not show you cartilage. That's number one. And if they do, like, they've eroded a little bit of the articular cartilage. That cartilage doesn't look like this. This cartilage is definitely abnormal and is beginning to make you feel that we are dealing with something that is not benign. Okay. Now, one of your differential diagnoses was a chondroblastoma. So now, do you think that this is a chondroblastoma? Because somebody said it was a chondroblastoma. Okay. So now tell me, Prayas, do you think that this is a chondroblastoma? Yes?
No, ma'am.
No, very good, Prayas. Why isn't it a chondroblastoma? Because now you're getting mixochondroid over here. And now you see the variation, which is very obvious. This is no longer looking benign at all. So now we have got abnormal cartilage, we have got giant cells, we've got all sorts of other things, and then comes an area like this. And what does it show?
Uniform pattern.
Cartilage here. It's very cellular. No longer are those stromal cells now are forming fascicles. Yes.
Uniform.
And they are also giving rise to bones. You see this calcified osteoid.
Yes.
So now we have got cartilage, which is abnormal. We have got very abnormal looking stromal cells, and we have got the cells that are also producing bone. Okay, I mean, it's calcified osteoid, and very soon that would become bone. We've got a very strange looking tumor, parts that look like a giant cell tumor. Okay, which would have, if everything looked like that, it would be a giant cell tumor. Parts that are looking like something that is almost like an osteogenic sarcoma, it is, because it's got this very spindly looking cells which are producing osteoid, which is calcifying. And we also know that osteogenic sarcomas can produce cartilage. Okay, they are known as chondroblastic osteogenic sarcoma. So we have got a very sarcomatous looking tumor, which also has got giant cells. And if you go on high power, you see that the cells look really very abnormal. Okay, in this particular field, I can't see any mitoses, but yes, there were mitoses in this tumor. So now what have we got? Come on, Prayas. Observations on radiology.
Ma'am, there is sharp radiolucency in the distal subchondral end of the epiphysis of the skeletal of the right mature femur.
Oh, yes.
And
this is likely to represent a GCT or a chondroblastoma. Yes, very good.
Yes.
Then, and this is what you have. You have a malignant tumor,
with osteoclast,
bone, cartilage, and
spindles.
spindle cells. Okay. So now what is this, Prayas? What is it? What do you think it is? So malignant tumor that produces bone and cartilage is what, Prayas? Huh? Osteogenic sarcoma. Very good. Can you get osteogenic sarcomas that have osteoclasts in them?
Yes, ma'am.
Yes.
Yes.
Excellent. So this has to be an osteogenic sarcoma. Okay. And a lot of people use immunohistochemistry now. They do SAT-B2. Okay. I think it's a ridiculous name, frankly, because any tumor that produces bone, and sometimes tumors that produce cartilage, which calcifies, will express SAT-B2, because SAT-B2 is not something that is only produced by osteogenic cells, whether they are benign or they're malignant. SAT-B2 is even expressed in colonic tumors, etc. So please, SAT-B2 is not to be used to make a diagnosis of osteogenic sarcoma unless there is no osteoid being produced and you still suspect that it is an osteogenic sarcoma, in which case, if you have a sarcoma in bone and it is SAT-B2 positive, you cannot find the osteoid, maybe on a needle core biopsy or otherwise, then you have a right to call this osteogenic sarcoma because SAT-B2 is positive. This is for people who routinely use SAT-B2. Please do not use SAT-B2 to prove that something is an osteogenic sarcoma if that tumor is already producing osteoid or cartilage or some other matrix which you
feel that you want to justify. Now, I will tell you this, that if you have a spindle cell tumor that is of peripheral nerve sheath origin and it is producing metaplastic bone and cartilage, SAT-B2 will be positive. And that, my friends, is not an osteogenic sarcoma. So don't use SAT-B2 unless you have a reason to use it and use it in a context. This may not be, for you postgraduates. I'm just making the point. But this has got some interesting immunohistochemistry, all right? Because the diagnosis was an osteogenic sarcoma. It was an osteogenic sarcoma in the epiphyseal portion of the femur, and it had giant cells, okay? Today, we have this protein, okay? And this is a mutated protein, and it is called H3.3G34W. Please write it down because you're going to see this more and more often, okay? I don't think that many of you are in institutions where you have access. If you have access to this antibody, that's wonderful, okay? What is H3.3G34W? It is a mutant histone. And not only is it a mutant histone, I'll tell you a little later what histones are if you don't already know, but it is a mutant histone that is expressed. It is expressed in giant cell tumors of bone. So whether they are benign or they are malignant, you will get the expression in the nucleus of this mutant histone. In fact, it is a fingerprint for a giant cell tumor of bone. There is no other tumor that gives you this mutant histone expression, okay? So here in the nuclei, you are seeing this. So this is a primary malignant giant cell tumor of bone. It's primary because secondary giant cell tumors, which show you, secondary osteogenic sarcomas that show you some osteoclast here and there, if they do not express this this mutant protein, then it is not a giant cell tumor of bone, which has become, an osteogenic sarcoma. Now, the giant cell tumors of bone can be primarily giant cell tumors, or they may have giant cell tumors which secondarily show you an osteogenic sarcoma over a period of time after several recurrences, etc. All those tumors will show you this H3.3G34W. Okay, it's a mutant protein. It's a mutant gene which produces this mutant protein, and that gene codes for a histone. So this is a very strange case which looks absolutely benign on radiology, but is a frankly malignant primary malignant giant cell tumor of bone, and the malignancy in this giant cell tumor, as we have already noted, is an osteogenic sarcoma. Are there any questions now, Prayas, or any of you, or anybody in the chat box? Loma? No, ma'am. No. Okay. So now we come to the last case. And Zara, do you want to take this?
Yes, ma'am.
All right, come on, Zara.
17-year-old male presenting with mild pain and swelling in the right knee for 10 days.
Excellent. All right. Now.
The X-ray shows a sclerotic rim lesion involving the sclerotic rim lesion involving the center of the epiphyses of the tibia.
Excellent. Very good. Yes. It has got a sclerotic rim. Yes. It's extremely well defined, right? So there is a narrow zone of transition, but it is also lytic. It's not entirely sclerotic, is it? No, the center of the lesion is sclerotic.
Yes.
It has got some, is lytic. It has some sclerosis because what you're looking at is a projection. No, you're projecting the back to the front, and you have that. Is this a mature skeleton or an immature skeleton?
Ma'am, it's an immature skeleton.
Immature. Why do you say it's immature?
Ma'am, because
Why do you say it's immature? You see the tibia here? Do you see this line?
Yes, ma'am.
There is a line there, right? And that line is lucent. So what is the lucency in that line between the epiphysis and the metaphysis tell you?
It is the cartilage.
It is cartilage. So